So good afternoon, and hopefully everyone can hear me well. Thank you for having me. You guys are brave to have this talk after lunch. This is probably not one of those conversations that you really have after lunch, but we'll see how it works. The pictures are not nearly bad, so you should not have any problems with your lunch and this talk. But we are talking about colorectal cancer. And we'll try to get through this. There'll be some of these pictures or slides I'm going to skip because I need to make good use of the time today. So if you see me skip past something, I'm going to try to get enough time so we have some questions and answers at the end, okay? So we're talking about colorectal cancer. And March is Colorectal Cancer Awareness Month, but we continue to talk about it throughout the remainder of the year because, again, it's a disease that affects lots of folks. Nearly 140,000 people will be diagnosed with colorectal cancer in this year alone. And that's a lot of people. And about 50,000 people will probably die from colorectal cancer this year alone. In South Carolina, we're talking about 2,300 cases a year are diagnosed. It's not just a South Carolina problem. Audrey Hepburn had colorectal cancer. So did, anybody know this, Eartha Kitt? She was cat girl in the 60s or 70s. Tammy Faye Baker had colorectal cancer. So did Boss Hogg from the Dukes of Hazzard. Samantha from Bewitched. Daryl Strawberry, a baseball player. Jackie Gleason from the Honeymooners. Roddy from The Price is Right. He was the voice announcer. It was very common saying, "Come on down, you're the next contestant." He died from colorectal cancer. So the disease itself is rather common, and unfortunately, we still have folks that are diagnosed with colorectal cancer even today. But here's the good news of it, is that if we can find these cancers when it's early, or when the stages are very, stages are 1 or 2, we have a better chance of survival. And overall, the 5-year survival can be approximately 65%. Most commonly, it's diagnosed in folks who are aged 65 to 74. Median age at diagnosis is 68. This is not a man or a woman's disease exclusively. Any person can get colorectal cancer. Men have a slightly increased risk, 1 out of 21, and women, 1 out of 23 will be diagnosed with colorectal cancer in their lifetime. On average, we're talking about 1 out of every 20 persons will be diagnosed with colorectal cancer in their lifetime. The highest risk we've seen in African Americans and have a higher risk of dying from the disease and even a higher stage at the diagnosis, which comes into screening methods that we'll talk about earlier. But the good news is that because we've been doing screening programs, we've been giving talks like this, we've seen that the overall incidence is decreasing in the United States, about 30% decreased incidence. We've seen that less folks are dying from colorectal cancer, but we know that probably 2 out of 3 or 60% of deaths can be avoided if we can do screenings and find these cancers earlier. As you get older, your risk increased of dying from colorectal cancer. Death is highest in folks ages 75 to 84. We've seen that folks under 50 can also be diagnosed with colorectal cancer. And this is something that's probably been quite startling because, as I just said, the overall incidence is decreasing, but the incidence in those under 50 is going in the opposite direction. The median age at diagnosis in this group is about 44 years old. And many of these folks actually have symptoms that are unfortunately ignored or disregarded by either the patient and or the doctor. So there are 2 words in colorectal cancer as we talk about this diagnosis: colon and rectum. And the colon and rectum represents the large intestines or the large bowel. It's a hollow tube. It's about 6 feet long. So if you were to take your whole colon and stretch it, it would be about as tall as you are. Okay? It connects the small intestines to the anus, and there are 4 particular layers in the walls of the colon and the rectum. It frames your abdomen. Think of a picture frame and put a picture frame against your abdomen. That's kind of how the colon is. It's like the picture frame of your abdomen. And again, these 4 layers are important because the cancer itself starts on the most the innermost layer. So that's called the mucosa. So if you're looking at this one, it's along this layer. If you're looking here, it's about here, okay? So that's the innermost layer, and this cancer grows through these layers to spread through other parts of the body. So let's talk about colon cancer first, and I'll separate them because of particularly how we talk about its treatment options. Colon cancer, again, is from everything from the beginning of the colon, so over here. Let me try to point, I think my pointer's out. So everything from here all the way down to here, okay? And it's made up of different parts, okay? So you have the ascending colon, or the right side, the transverse colon, which is kind of this middle part, the descending colon, or the left colon, and then this funny S-shaped part called the sigmoid colon. Those make up the large intestine from the colon. The rectum is the bottom 5 to 6 inches, so it's this bottom part down here, okay? So the rectum's not this exclusively is the large intestine, but this is rectum, that's all colon, okay? And again, this cancer starts in the mucosa, or the innermost layer. It grows from a polyp, which is basically just a bump, if you can imagine, that starts in the colon that continues to grow. Okay, and we don't really know exactly why all these polyps grow. Occasionally, it's because the body doesn't respond as it normally should and shut off production of these cells, so they continue to grow and get larger and larger. Not every polyp itself is cancerous. The ones that are cancerous are called adenomatous. That's a funny word right there, adenomatous. So those are those precancer polyps, and those are the type that will grow to become cancer. All right, and this cancer grows through the bowel wall. This is an example of what these polyps look like in the colon, and these are polyps, again, that we can remove and find during a colonoscopy. There's several myths related to colorectal cancer, and one of which you've probably heard is that if you have air that gets exposed to the cancer, then it's going to cause it to spread. Have you ever heard that? Yeah. And this has stopped many people from many persons from not actually having a colonoscopy or even having surgery, because they say, well, if you open and you expose my insides to air, it's going to create the cancer to actually spread to other organs. And that is exactly not true, okay? That's not true. Cancer, colorectal cancer spreads primarily through 4 means. It spreads through the bowel wall, or through those 4 layers that we talked about. It spreads around the inside of the abdomen to other organs. It spreads through the lymph nodes and even through the bloodstream. And there's a picture that I'll show you that shows these various ways, right? So in stage 1 cancer, we're talking about a cancer that is confined to the colon. It's not spread to any of the lymph nodes. And the lymph nodes are important because the lymph nodes around your colon connect with the lymph nodes in other parts of your body, all right? So if a cancer cell has escaped and is now involving the lymph nodes, that lymph node can then spread through other parts of the body. Think about it like this. Think about the lymphatic system as the interstate of the body, all right? So you can get in your car, you can leave from this parking lot, and you can head to the interstate. Let's say I-85. You can get on I-85 and you can go anywhere in the country, all right? You can, through a circuit of other interstates, you can get to Chicago, you can get to California, you can get to New York, you can get to Miami. It can spread throughout anywhere across the country, where the lymphatic system is exact same, all right? So a cancer cell can get involved with the lymph node, and that lymph node can carry it basically throughout the rest of the body as well. And that's another way that cancer can spread. Another way it can spread is through the bloodstream. So this picture here, it doesn't show it as clearly, but by the time that you have the higher stages, you have blood vessels that then spread it throughout the bloodstream through other parts of the body as well. You can make out from this picture a couple of other things. You see how small this tumor is versus this one? Which one do you think is going to cause more problems? The big one, right? But you can still have a cancer that's that small that won't cause any problems at all. And it's sometimes startling for folks to come in and they say, well, I'm not having problems. How are you telling me I have cancer? I'm not having pain, I'm not having bleeding, because sometimes when it's so small, it's not large enough to cause problems, right? Another thing, What else do you notice about how big this particular cancer is compared to this one?
It's pushing through the layers.
It's pushing through the layers, absolutely. It's involving the lymph nodes. And if you can imagine, what you don't see here is Mr. Poop, right? I'm sorry, you did have lunch. I'll try to keep it clean, right? So you have stool that passes through the colon. As you get larger, it creates potential more issues with the stool going past it. And that's why sometimes folks with larger tumors have blockages. That's how it gets found in many cases, because it gets to be so large that it's hard for the stool to get past, and therefore folks begin having more pain, more perhaps nausea or vomiting, and it can in some cases cause perforation, where a hole is created in the colon in certain areas. So the concern that many folks have when they hear that they may have to have surgery for cancer is they don't want to have the bag. They don't want to have a colostomy bag or an ostomy, and so therefore they don't want to have surgery. And in many cases, if done electively, maybe in a non-emergency, we can do surgery without having to have a colostomy or a stool bag. There's several different types of surgery that we offer. One type is where we remove the right side of the colon. That's called a right colectomy, right? And we do a new connection between the small intestines and the large intestines, all right? This gets really complicated, right? If we remove the left side, that's called a left colectomy, and we connect here down to here, all right? And the same is true if there's a cancer involving the sigmoid colon. We take that part out, and we make a new connection. So my father is a contractor by trade, and so he does a lot of plumbing work, and he tells his buddies that his son, the big-time colorectal surgeon, is a plumber. Right? Because that's essentially what we do. We basically work with the pipes. So if the bad part of the pipe isn't working, we take that part out and we do a new connection. That's as simple as it gets. And in many of these cases, you don't have to have a colostomy. So how do we treat colorectal cancer? Well, it depends. It depends on the stage, right? It depends on those layers that are involved, or the lymph nodes that are involved, or if there are other organs that are involved. The earlier stages can be treated primarily with just surgery. The higher you get, we talk about perhaps adding chemotherapy. In rectal cancer, we talk about the addition of radiation if the stages are more advanced, okay? And that's primarily because the rectum is in such a confined space. We want to make sure that we've cleared any potential cells in that confined area. We talk about laparoscopy as another way to do surgery, where we use the cameras, like how we do gallbladder surgery a lot of times, where you have smaller incisions and quicker return of bowel function. But we also do robotic surgery now. And that's surgery where, again, the incisions are kept small. Folks have a quicker return of bowel function. It's the exact same surgery. And you don't have to be afraid that the robot is working by itself and that you're not in any more danger from the robotic approach. But it's another way in which we offer surgery today. We mentioned this earlier. If you have signs or symptoms, again, that can mean you have colorectal cancer. But it doesn't necessarily mean that if you don't have signs or symptoms, that you don't have the disease. How do we find colorectal cancer? Well, one of two ways. Either folks come to have symptoms, or they come to have a screening examination. What are the symptoms that we talk about? Well, number one, blood in or on the stool. It's sometimes related to hemorrhoids, but not always, okay? So I tell folks that if you're treating your hemorrhoids that are causing bleeding, and you're still having bleeding after treating your hemorrhoids, we may need to make sure there's not something else going on. It could be, again, something else that we need to pay attention to. So that's one symptom. Another is a change in bowel habits, meaning if you're someone that has a bowel movement once a day, and all of a sudden you have a bowel movement once a week, or you're somebody that normally has a bowel movement once a week, and now you have one 5 times a day, that's a change, okay? Or perhaps the stools have changed. Maybe they're thinner. You know, we talk about having stools that are pencil thin, very thin stools, certainly if that's an acute change, that could be a sign or symptom as well. Abdominal discomfort. Many things can cause abdominal discomfort, right? But certainly that one that is persistent or different than any that you felt before, that may be something that you need to have checked. Bloating or a sense of fullness or cramps or even nausea or vomiting, that can also be a symptom. This is a picture taken from a colonoscopy that shows one of those really large tumors that we showed earlier in that cartoon. But you can see again, it's causing some bleeding. It may cause some blockages as things are going through. And depending on how far it's grown or how deep the roots are, it could also cause pain or discomfort. So we don't want folks to wait to have that really large tumor. We want folks to get checked before that even happens. So we don't want you to wait for symptoms. We want you to have a screening examination. There are many different ways in which we screen or check for colorectal cancer. The one that we find most effective is the colonoscopy. But there's some patients that won't have a colonoscopy regardless of how much we ask of them or plead with them or try to encourage them. They're just not going to do it. And so I say that really some form of screening is better than no screening. We can prevent colorectal cancer with screening. And that's one of the reasons why we like to do these talks and we like to advocate folks get the colonoscopy, because this is a cancer that can be prevented. It can be prevented. And we can save over 90% of lives, and we can cure it early if we can diagnose it early. We can save up to 40,000 lives, and despite this, 1 in 3 persons are not up to date with their screening. So I'm not going to do the math around your table, but you can count off in threes, and afterwards you can have a little conversation with your group to make sure that your 3 are all caught up with their colon screenings. How do we screen? Well, there are different ways, okay? One of which is by checking the stool for blood or by doing a smaller scope called a flexible sigmoidoscopy. We could also check a barium enema, which is an X-ray type test, or do a CT scan that can also check for it. And then there's the colonoscopy. Now there's a lot of words on this slide, but there are a couple of things that I want to stop and talk about. Is that depending on the type of test that you do, it may change the frequency or how often you have to do that test. If you do a colonoscopy and it's perfectly normal and there's nobody in the family that has any problems, then you don't need to do another one for 10 years unless there are problems that it should start. However, if you choose to do one of the other tests, maybe you just want to check the stool for blood or do one of those fancy DNA type tests, you may have to have that checked every 2 years, every 5 years, depending on the test itself. And also, if any of these tests are positive, say you do one of these tests and it comes back as something's abnormal, it may then lead to having a colonoscopy as well. So who actually gets the screening test? Everyone. And when does it start? Well, it starts at different times for different people. And it primarily depends on the risk factors as being one indicator for when it should start. The average risk used to be 50 years old. Okay, we used to say at 50 years old, everyone should have to have a colonoscopy. And I put a star by that because that's changed. Over the past year, the American Cancer Society has advocated that we begin screening at the age of 45 because, again, we're seeing more younger people have colorectal cancer. That 45 has not really caught on with everybody. Most of the big societies have said 45, but some of the insurance companies haven't. So I say talk to your doctor. But probably in the next year or so, it's going to be more common that folks will, again, all agree on that age. Higher risk, again, talk to your family. Screening for African Americans should already be at 45 years old because of that increased risk that we talked about earlier. But what are the risk factors that increase the risk of colorectal cancer? Well, age. The older you get, the higher your risk, all right? If there's a personal history of colorectal cancer or polyps, meaning you've had polyps on other tests, that also increased your risk for colorectal cancer. If there's a family history of colon cancer or polyps, meaning your mom, your dad, your brother, your sister, that increases your risk as well, and that should also indicate needing to have that test. It generally doesn't mean if your grandparents or of your cousins, that doesn't really increase your risk unless there are multiple of those family members that have been involved, or one that was diagnosed quite early in age. A history of Crohn's disease or ulcerative colitis, that could also increase the risk. And diet. Diets are high in red meats, processed meats, fats. Those things can increase your risk as well. And physical inactivity, okay, not being as active can also increase the risk. But many people don't want to have a colonoscopy because they think it's uncomfortable, it's unpleasant, and nobody wants to take the prep, right?
Right.
You don't have to agree so much on that one, right? But the preps are not as bad as they used to be. We actually, oh, okay, maybe not. No, we actually use now a couple of different preps, one of which just has maybe 6 or 8 ounces of liquid that you drink times 2. So you do 6 or 8 ounces, some clear liquids in between, and then another 6 or 8 ounces. The preps have improved. They've come up with various different types of preps. One of the meetings we went to a year or so ago, there was a smoothie type prep. So check us out. But the preps are not as bad, and it's very important that we do a good prep so we can actually see everything we need to see. But the test itself is a 30-minute test. Someone drives you home. We give you sedation for it. It's a great nap. You get some medication, and most folks wake up actually wanting more of that sedation because it's a Michael Jackson drug. That's what we use most of the time. But we place a long, flexible tube through the bottom, and we look around the entire colon. Okay, and when we're doing it, we're looking for polyps. We're normally looking to see very clean. We can see the lining, the innermost lining that we talked about, the mucosa, and we can see everything that we need to see to make sure you don't have colorectal cancers or polyps. If we find a polyp, we can remove it while we're there. Again, this is why we can prevent these cancers from occurring. We can use things like snares, and this camera has a light on the end of it that really illuminates quite nicely everything that we need to see. Just because you have a polyp doesn't mean it's cancer, all right? We can prevent these cancers by removing these polyps. And this is another example of types of these polyps. That's a small polyp. That's another small polyp that we can also remove. And you can see this much larger mass that, again, is likely a cancer and will require probably surgery to get rid of it, all right? Again, better reasons why if we can find these polyps when they're small, we don't have to potentially talk about surgery.
Do you test every polyp?
Yes, ma'am. Yes, ma'am. We would. Her question was, do we test the polyps that we remove? And we do, because some polyps can have a small amount of cancer or something like that. So we do send off these to the pathologist. There's a big push for folks to go through bowel cleaning and having colonics, and folks that believe that the colon's making them sick by not being empty. And we really think that there's several functions of the colon that are more important. The colon's primarily responsible for preparing waste for elimination. What you eat, it has to leave, right? And the colon is responsible for storage, and then also responsible for emptying that waste when it's appropriate. You do absorb water and salt in the colon, and there's bacteria that's present, that should be present, to help your body function normally. When that equilibrium is off balance, perhaps because of antibiotics, that's when we talk about people having C. diff and other types of opportunistic bacteria. The big question is always, well, are my bowel movements normal? Okay, and I guess if we were to break off, we could have a conversation for the rest of the day with this group alone about your bowel habits, all right? So here's the kicker. There is no such thing as a normal bowel movement, okay? Normal doesn't exist, right? Everybody has a different normal, right? So when you get into trouble, when you start talking to your buddies about their bowel movements, because theirs are going to be different than yours, and then you get jealous, and then you then want to compare and figure out how you can compete with them. Don't compete with your neighbors about your bowel movements, all right? Because they're different. Normal doesn't mean the same thing for everybody. But we know that constipation, when folks say, I have constipation, that primarily indicates you're having less than 3 bowel movements per week, okay, over a long stretch of time, okay? So just because you didn't have a bowel movement today doesn't necessarily mean you're constipated, it just means you didn't go today, okay? Normal can be up to 3 times a day, or it can be as few as 3 times a week, all right? And that's, again, different for everybody. People use sorts of treatments such as colonics, and I tend to tell folks to stay away from these types of things as they can create problems. Colonics and things like that can create problems with electrolyte imbalances that can be damage to the intestines. So I tend to steer folks away from that type of thing. But what I do recommend that you do is to eat diets that are high in fiber, staying away from a lot of the processed meats, a lot of the good stuff, staying away from some of the cured meats, not eating as much of the hams and the hot dogs and the stuff that right, I'm sorry. But not eating as much of that. And really using meat, if you're going to incorporate meat in the diet, really using it as the side dish instead of the main dish. If you go to a restaurant today and order food, the meat's going to take up most of the plate, right? And really to reverse that, consider meat as more of the side instead of the main dish, and using the veggies and the whole grains as the main part of the dish. Plenty of water, and making sure you have plenty of fiber, right? So that's like the Metamucil, the FiberCon, the Benefiber. They have fiber gummies, pills, all the other stuff. Incorporating that in the diet can be helpful, all right? And there's several things as we talk about moving forward at how we screen. The way we screen for cancer obviously is evolving. Now we even check for DNA in the stool. We check for other things that they're talking about, or markers in the urine as well, and kind of how we find these cancer. That's probably one of the newer things, or the technology and how that's changing. So we have some time for some questions, and I know that there are some. But before we go, I'd just like to remind you that overall, the prognosis of colorectal cancer is dependent on the stage. The earlier we can find these cancers, the better the prognosis, all right? And to tell your family and friends that colon cancer can be prevented. And that's why you are now the ambassador that takes it back to your family and friends and tell them, get your colonoscopies so we can prevent other colorectal cancers from occurring. We now have time for some questions.
How often do you recommend colonoscopy?
So if it is, her question was, how often do you recommend colonoscopies? Well, it depends. If the test was normal and there's no family history of any problems, we recommend every 10 years. The other question that comes up is, if I've reached the age of 75, do I need to have another colonoscopy? As there may be someone here in here who's over the 75-year-old age, I think that depends, all right? There are some 75-year-old patients that are quite healthy, and that may live another 25 to 30 years. And I think, some groans over here. And I think that depends. I use individual conversations to decide when we discontinue the use of the colonoscopy. Most of the recommendations will say at 75 we stop doing them. But again, I have some 80-year-old patients that are very healthy, still walking a mile or two, still involved with their church, still going out and traveling, and so I base that. The oldest patient I've operated on was 99 years old. She was 99, and she presented with a colon cancer because she was having trouble, and she wanted to have surgery. And I ultimately tried to convince her and her family to wait, and she was going to turn 100 in a month. And I said, can we just, because I didn't want to be responsible if something happened and the party would be canceled. I just said, can we please wait to after? And they said, no, we want to do it now. And she did it then, and she just really celebrated her 102nd birthday. She just turned 102. So there you go, right? But that's not common, right? But we have several folks that are in their 90s that have had colon cancer that want surgery. So again, we base that depending on the patient and their other risk factors and medical problems. Yes, ma'am. So she asked, what's the name of my practice? I'm with UMG, the Department of Colorectal Surgery. The Department of Surgery, the Division of Colorectal Surgery. Clifton can get you guys more information. I do have a few cards, but I'm at Prisma Health. Prisma Health, I'm in there.
So you're here?
Yes, ma'am. So I'm in this health system. in this health system.
What about probiotics?
Probiotics. So they've really been thought to be the wonder drug. And ideally what their function is to restore some of the good bacteria. I don't think it is the medication or the savior that people want it to be. It can be helpful in regulating bowel activity, but I do think you still have to have the fiber. There are several different types of probiotics. There's some pills that you can take. There are also the type like the kefir, that's like the smoothie drink that you can buy from some of the grocery stores that you can use as well. The yogurts also have the bacteria that can help replenish. Perhaps if you've been on prolonged antibiotics, they can help replenish some of that. Yes, ma'am.
Okay, so when you're on antibiotics, that kills off the good as well as the bad bacteria. Does the intestinal tract just regenerate and replenish itself over time?
Yes, ma'am. So she asked, will the intestinal tract regenerate some of those bacteria? Over time, it will, but many folks now rely on probiotics to help with that. Yes, ma'am.
Is it true that after 75 our skin gets so thin that you don't want to do this blood test?
Say that again?
Is it true that when you reach over 80, that the skin is so delicate that you're afraid to do it?
So that is a concern, is if you've gotten to be a certain age, might the intestine or the walls be very thin? And I'm not sure that it's thinner, but I will tell you that in some cases you can, perhaps one of the complications is the risk of perforation or poking a hole in the colon. And that can be a tough complication to recover from, no matter what age, especially if you're older, because there can be other medical problems that make it harder for you to recover, especially if you require surgery or have other infections as a result of it. Do we have time for maybe one more question? Yes, ma'am.
What do you think about the Cologuard?
So the question was, what do I think about the Cologuard? So the Cologuard is another type of screening test that checks for the DNA within the stool. I think it's certainly it's an option. There are two things that I have to say about Cologuard, that if it's positive, it still may require colonoscopy. I've seen several folks that had a positive Cologuard that came in and actually thought they had cancer because of that test. I don't think I've had one that has actually been found to have cancer associated with it. So I try to let folks calm down a little bit if they have a positive test. And the second thing is, if you do a Cologuard, it may not be every 10 years. Okay, it's going to be much more frequent. It may be 3 years or 5 years. It depends on your risk factors. So the Cologuard is not meant if you're having symptoms, meaning if you're having bleeding, if you're having these pains, Cologuard is not the test of choice. The Cologuard is meant as a screening test, meaning you're not having any problems at all, and we just want to test for colon cancer, and because it is an option, that a lot of folks use it now. Thank you so much for having me come today. Enjoy the rest of your day.